In Module 8 we will cover types of instruments, assessment considerations, and cardiovascular fitness. There are two types of instruments, which as objective and subjective instruments. Objective instruments do not require interpretation of behaviors by the participant or a trained observer like steps picked up by a pedometer. While subjective instruments require participant or trained rater to use judgment in determining the score, such as self-reported questionnaire. When it comes to the different methods of assessing physical activity, we can classify it into several categories as following: motion sensors, heart rate monitors, calorimetry, doubly labeled water, physical activity diary, and recall questionnaire. The first four categories are objective instruments, while the latter two are subjective instruments. The proper assessment or measurement of physical activity is a challenge, especially in free-living individuals. The assessment tool must elicit accurate information on the types of physical activities that encompass the greatest proportion of energy expenditure in the study population. If not, the assessment tool will fall short and lead to an inaccurate assessment. That is, accurate assessments are needed to better understand the specific amounts of physical activity that are needed for health benefits, as well as determine if a particular behavioral intervention was successful in changing activity behavior. Accuracy is the degree to which an assessment tool is able to measure physical activity and/or exercise. Accuracy is comprised of both validity and reliability. Validity is the degree to which an instrument measures what it sets out to measure. Reliability of an assessment tool relates to its repeatability. Will the results that were obtained with a particular assessment tool be replicated if the test is repeated? Sensitivity relates to the ability of an assessment tool to accurately measure and detect change in physical activity patterns. Questionnaires and surveys are subjective instruments used in epidemiological research to quantify physical activity. Physical activity questionnaires or surveys can vary by complexity, time frame, or recall, and types of activities surveyed. Complexity. Physical activity questionnaires can vary in complexity by the manner in which it is administered, self versus interviewer. They can also vary from the use of a single question to more complex questionnaires that attempt to survey a wide range of popular activities over a predetermined period of time. Time frame of recall. Questionnaires/surveys may inquire about usual activity done within the past day, past week, past month, past year, or even over one's entire lifetime. Types of activities. Early studies in physical activity epidemiology estimated one's physical activity based on the activities that were performed at work. However, as a country becomes more industrialized, the amount of physical activity accumulated on the job and/or as a means of transportation declines. As a result, investigators shifted towards questionnaires and surveys that measured only leisure time physical activity. In addition, for older or diseased populations, the assessment of lower intensity activities, such as household or activities of daily living, may be necessary when determining one's physical activity status. Subjective measures are less likely to capture lower intensity activities because it is often difficult to accurately recall lower intensity types of physical activity such as housework and child care. For accurate assessment of low-intensity activity, objective measures are needed. Here are the pros and cons of the questionnaire or survey. Pros of the questionnaire/survey include their non-reactiveness. The individual's behavior will usually not change as a direct result of the assessment technique. Also, questionnaires/surveys are practical because they are low in cost and relatively convenient to the participant. Another benefit of the questionnaire/survey is its applicability and ability to be modified to suit the population of interest. Finally, Questionnaires/surveys have acceptable accuracy, both reliability and validity, in situations where the investigator is trying to measure differences in physical activity levels between groups. Cons. Physical activity levels obtained from questionnaires do not reflect total energy expenditure for a particular individual because they do not consider the energy requirements of such things as basal metabolic rate, thermic effect of food, and in most cases, activities of daily living, lower intensity activities. There may be assessment issues surrounding an individual's inability to accurately recall activity. Different populations may interpret physical activity in different ways or participate in different types of activities. Therefore, the subjective measure should be modifiable to fit the needs and interests of the population. Direct observation not only measures physical activity, but also identifies the type and specifics when, where, and with whom of the activity. In recent years, it has been mainly used in children. Pros. Direct observation provides both quantitative and qualitative information on an individual's physical activity. Also, physical activity behaviors can be specifically targeted due to the fact that physical activity categories are established a priori. Cons. Direct observation involves a time and labor-intensive data collection, therefore, it may not be feasible for use in large epidemiological studies. Also, the observer's presence may alter the participants' normal physical activity patterns. Finally, there is limited research regarding the validation of direct observation against physiological criteria. Indirect calorimetry measures oxygen consumption and carbon dioxide production over short or long periods of time. For short durations, participants wear a face mask during rest and/or exercise. For longer durations, individuals are confined to a metabolic chamber. Doubly labeled water is a biochemical procedure that estimates energy expenditure through the use of markers that reflect the rate of metabolism in the body. During the procedure, 2 stable isotopes of water are ingested by the study subject. After a 1 to 2 week period, investigators determine how quickly the body lost the water isotopes. The water isotopes can be lost through urine, sweat, and/or evaporation. The investigators measure the difference between the rate of loss of the 2 water isotopes to determine energy expenditure. Pros. Indirect calorimetry and doubly labeled water are precise and accurate measures of total energy expenditure. Cons. Both indirect calorimetry and doubly labeled water have high participant burden, and both measures are costly, therefore, may not be feasible in large epidemiological studies. Heart rate monitors are used to assess heart rate response. Pros. Heart rate monitoring is valid in both laboratory and field settings. Also, there is low participant burden for short monitoring periods. Heart rate monitoring is able to provide information relating to workload/intensity, frequency, and duration of physical activity for adult populations. It is an easy and quick method, making it practical for large studies. Cons. Heart rate monitoring can be expensive, there may be possible patient discomfort if the monitoring period is lengthy, and it is only useful for aerobic cardiovascular activities. Finally, characteristics of heart rate, especially among trained individuals, may affect the relationship between heart rate and energy expenditure and may lead to inaccurate results. Activity monitors, often referred to as accelerometers, assess the acceleration of the body in a specific dimension, uniaxial or multiple dimensions, triaxial. The monitors provide information on the intensity of acceleration at specified intervals. Following data collection, this information is downloaded to a computer for data processing. Pros. Objective measure of body movement that has been found to be valid in both laboratory and free living settings. Activity monitors have the ability to provide information relating to intensity, frequency, and duration of physical activity. They are also non-invasive and have the ability to record over extended periods of time. Cons. They are costly and do not provide information concerning activity type. Also, the uniaxial monitors may be inaccurate during upper body movements and during bicycling. Most activity monitors are not waterproof, therefore, water-based activities cannot be assessed. Also, improper monitor placement may lead to inaccurate results. The pedometer is another type of movement monitor that counts steps taken throughout the day walking, jogging, running. Pros. Pedometers are objective measure of walking, a common type of physical activity. Pedometers are inexpensive, non-invasive, and easy to administer, making them practical to use in a variety of settings. Pedometer step count feedback can be used to promote behavior change. Cons. Pedometers were specifically designed to assess ambulatory movement and are not accurate in assessing activities that move away from ambulation e.g. bicycling. Also, most pedometers are not waterproof and cannot be used to assess water-based activities. Proper placement is essential for accurate results, and pedometers may be subject to patient tampering. In the recent past, GPS and GPS-embedded sports bands or watches have been prevalent in various populations. We will elaborate the emerging technologies in the future lectures. This slide shows a number of objective instruments that are widely used to assess physical activity, including actigraph accelerometers, Actical accelerometer, and New Life 1000 pedometer. This slide also demonstrates a variety of emerging technologies that are prevalent in assessing physical activity in the past decade, including sports watch, smartwatch, Fitbit, pedometer, and ActiTrainer. Physical fitness can either be health-related physical fitness or skill-related physical fitness. Health-related physical fitness encompasses attributes that are thought to be related to improved health, such as reductions in chronic diseases, injuries, and rates of disability. It includes aerobic capacity, muscular strength, muscular endurance, flexibility, and body composition. These components are usually the attributes we are most interested in changing or improving when promoting physical activity or exercise in public health. Skill-related fitness attributes are those that are the most important for successful movement and sport participation. They include balance, agility, coordination, power, and speed. They are also more likely to be determined by genes than by physical activity. They may or may not be related to health outcome. For example, balance is important for some competitive sports, and it is also critical for preventing falls in the elderly. Speed is a very important fitness component in track and field. Yet people can be healthy without being running fast. The measurement of physical fitness is common practice in both preventative and rehabilitative exercise programs. The purpose of fitness testing includes educating individuals about current fitness status relative to population norms, collecting baseline and follow-up data to measure progress in an exercise program, motivation of exercise participants, and risk stratification for chronic disease development. Cardiovascular fitness will be emphasized in this lecture. Cardiovascular fitness can be measured directly using maximal exercise testing VO2 max or indirectly using submaximal exercise and field test protocols. Because physical activity is difficult to measure, maximal oxygen uptake or VO2 max is often used as a proxy measure of physical activity. However, VO2 max is actually a measure of physical fitness, not physical activity. Those who are more active and expend more energy tend to have higher fitness levels. Many VO2 max protocols are time-consuming and may not be possible in large epidemiological studies where there are a great number of participants. In addition, when examining population studies, there is only a moderate relationship between physical activity and physical fitness. This lack of a strong relationship could be due to the fact that there are other factors besides activity, such as genetics, gender, age, and relative weight that influence physical activity. In instances where VO2 max testing is not practical, such as with large epidemiological studies, submax VO2 and field tests have been used to estimate VO2 max. Submax VO2 tests use heart rate to predict the oxygen consumption that would have occurred during maximal workloads VO2 max. Submax VO2 tests are able to predict VO2 max because of the linear relationship that exists between heart rate and exercise workload/intensity as workload/intensity increases. HR increases ACSM, 2000. Similarly, field tests use either the distance that is covered or the amount of time it took to cover a particular distance to estimate VO2 max using established prediction equations.